Okay, hello everyone. Nice to meet you all. You can see the screen. Please tell me. Can you see the screen? Is it full screen? Is it full screen in front of you or divided one?
Yeah, that's full screen.
Full screen now. Okay, that's awesome. So today we are going to approach a case of hypercalcemia, which is a very common case actually in our medical field. And most of the cases of hypercalcemia are discovered accidentally, during routine bloods or basic blood investigations. But of course, hypercalcemia could be serious if untreated. So we have to know how to approach a case of hypercalcemia if you found out that the patient is hypercalcemic. First of all, we have to divide and to know the grades of hypercalcemia, because according to the grade of hypercalcemia, we can make decision regarding admitting the patient in the ward or discharging the patient home. So the grade and symptoms of hypercalcemia can determine which patient should be admitted to receive immediate treatment and which patient can be discharged home for further investigation as outpatient. So first of all, mild hypercalcemia. Mild hypercalcemia is defined as ionized calcium between 5.6 to 8 milligram per deciliter, or total calcium is more than 10.6 or between 10.6 to 12 milligram per deciliter. Actually, what we are using here in UK is milligram per deciliter, but in United States and other countries, they are using millimole per liter. So let's use milligram per deciliter as we are using here in our UK trust or NHS trust. So again, mild hypercalcemia is between ionized calcium between 5.6 to 8 milligram per deciliter, or total calcium between 10.6 to 12 milligram per deciliter. And most of these patients are asymptomatic. They don't have symptoms. And these patients can be charged home. Can be charged home with advice for good hydration and avoid drug including calcium, and to do investigation as outpatient. Moderate hypercalcemia. Moderate hypercalcemia is defined as ionized calcium between 8 and 10 milligram per deciliter. And total calcium between 12 and 14 milligram per deciliter. What we are using here actually is total calcium in most of the cases. And presentation of such cases of moderate hypercalcemia is tiredness, fatigue, increased thirsty, impaired sensorium or constipation, polyuria, and polydipsia. And in a case of moderate hypercalcemia, if the patient is symptomatic, such patient need admission actually for IV hydration and further investigation. Severe hypercalcemia, or known as a hypercalcemic crisis, such patients are defined as ionized calcium more than 10 milligram per deciliter, or total calcium more than 14 milligram per deciliter after correction of the calcium. Of course, we have to do corrected calcium after evaluation of the serum albumin. Such cases of severe hypercalcemia may present with serious manifestation, like maybe arrhythmia, altered conscious level, coma, pancreatitis, peptic ulcer disease, and in addition to symptoms of moderate hypercalcemia, including nausea, vomiting, polyuria, polydipsia, and increased thirsty and dryness. Of course, severe hypercalcemia is considered to be life-threatening condition. That's why such patients need immediate admission and immediate treatment that we are going to discuss later. So again, briefly, only patient with moderate hypercalcemia and symptoms should be admitted, and in addition to severe hypercalcemia should be admitted. Mild hypercalcemia patient, no need for admission. This patient might need just further investigation as outpatient and no need for admission, with of course advice for good hydration, drink a lot of water, liters of water, and to avoid medication rich with calcium like vitamin D derivative, and avoid dehydration. Causes of hypercalcemia. It's very important actually to know what the cause of hypercalcemia, because according to the cause, the management will be different. For example, hypercalcemia secondary to malignancy is treated differently from hypercalcemia secondary to primary hyperparathyroidism, treated differently due to because of hypercalcemia secondary to sarcoidosis, for example, or lymphoma. Every cause has a specific treatment. So number one is parathyroid hormone-related causes of hypercalcemia, which is the most common cause of hypercalcemia actually in our medical field. You'll find such patients have primary hyperparathyroidism, could be sporadic or familial, associated with MIN1 or MIN2. And also tertiary hyperparathyroidism associated with chronic renal failure or vitamin D deficiency. These are the hypercalcemia secondary to parathyroid hormone related disease, either primary hyperparathyroidism or tertiary hyperparathyroidism. Vitamin D related, it could be exogenous or endogenous. Exogenous because of vitamin D toxicity. A patient is taking a lot of vitamin D for a long time with large doses, or endogenous because of granulomatous disease such as sarcoidosis, borreliosis, tuberculosis, and in addition to Hodgkin lymphoma, which in such condition there is increased secretion of 1,25 dihydroxy vitamin D. Malignancy, of course, is well-known and common cause of hypercalcemia, either solid malignancy like breast cancer, lung cancer. The most common solid cancer are squamous cell carcinoma of the head and neck, renal cell carcinoma, lung cancer, and the method or the mechanism of hypercalcemia in such cases is mediated by paraneoplastic syndrome. Such solid cancer are secreting polypeptide-related parathyroid hormone. Also, other type of cancer like multiple myeloma, and breast cancer can cause hypercalcemia by the effect of local osteolysis mediated by cytokines. Other causes of hypercalcemia and endocrinological causes of hypercalcemia, including hypercalcemia, acromegaly, pheochromocytoma, adrenal insufficiency, but such condition cause very mild hypercalcemia actually, and it shouldn't be treated. It could be corrected actually when you are treating the underlying cause itself. Genetic disorder like familial hypocalciuric hypercalcemia, FHHH, which is uncommon actually, it's a rare condition, but it can be misdiagnosed as a case of primary hyperparathyroidism because both of them have the same presentation or the same lab character, normal or high parathyroid hormone and high calcium level and low phosphate. To differentiate between familial hypocalciuric hypercalcemia and primary hyperparathyroidism, you have to do what's called calcium creatinine ratio. If calcium creatinine ratio is less than 0.02, this is the familial hypocalciuric hypercalcemia. We are going to talk about investigation later on. Familial hypocalciuric hypercalcemia is a hereditary condition, but is a rare condition which doesn't require treatment, by the way, and the most of these patients are asymptomatic. Other condition may be associated with hypercalcemia is immobilization in elderly patient, especially or patient with high bone turnover, including Beckett disease and bound to bed patients. And also recovery phase of rhabdomyolysis. Symptoms and signs of hypercalcemia. Again, it's easy actually. We have abbreviation which make it very easy, which is moons, stones, groans, and wounds. Okay. Moons is gastrointestinal symptoms, including nausea, vomiting, constipation, decreased appetite, abdominal pain, pancreatitis, and peptic ulcer disease. This is moons, which is related to gastro-GIT symptoms. Stones is related to kidney-related stones. So flank pain, kidney stones, and frequent urination. This is stones. Crohn's is related to psychological disturbance, including confusion, dementia, poor concentration, lethargy, memory loss, depression, and anxiety. So, moons, stones, groans, and bones. This condition may cause bone pain and bone-related disorder like bone ache and pains and fractures. ECG changes related to hypercalcemia is very important actually in any patient with hypercalcemia to check his ECG because hypercalcemia could be arrhythmogenic electrolyte disturbance. So you need to check if there's any ECG changes, especially a short QT interval and Osborne wave, which is G wave. This is the short QT interval, which it should be around 0.12. But in the case of hypercalcemia, it could be prolonged, like you say. This is a normal QT interval. In the case of shortened QT wave, it could be shortened less than 0.12. And also you can notice the Osborne wave or G wave. This G wave can found also in the case of hypothermia, which is a notch, attached to or straight after the QRS complex, you can find this Osborne wave of G wave in a case of hypercalcemia and in a case of hypothermia as well. Investigation for hypercalcemia. Actually, you have to start investigation step by step. So the first of all, you have to ask for basic investigation, including full blood count to check for any evidence of anemia, which could be because of underlying malignancy, for example, or because of chronic liver disease. ESR is very important actually to check for any underlying inflammatory cause, especially sarcoidosis and granulomatous disease. You will find ESR is high. Urea and electrolytes is very important because you will find the patient in most of the cases of severe hypercalcemia are dehydrated with high urea and create. And also to detect what is the underlying cause of hypercalcemia, because if you found that the patient has chronic kidney disease, probably this is tertiary hypercalcemia, tertiary hyperparathyroidism causing hypercalcemia. Liver function test is a basic investigation to check for if there is any deranged LFTs and which could be indicator of underlying liver malignancy or metastasis. Bone profile is very important as well. Bone profile including baseline calcium level and corrected calcium, alkaline phosphatase. High alkaline phosphatase could be indicator of underlying malignancy. Low phosphate and the normal ALP, for example, could be consistent with primary hyperparathyroidism, while elevated LP could be indicator of malignancy. So everyone or every single blood test could be indicator of underlying disease or underlying condition causing hypercalcemia. So these are the basic blood investigation. What the next step after asking for basic blood investigation? Next step is parathyroid hormone. Parathyroid hormone. Okay, if you found that parathyroid hormone is normal, which is called inappropriate normal or high, with high calcium, this is either primary hyperparathyroidism or hereditary familial hypocalcemic hypercalcemia or lithium-related hypercalcemia. How to differentiate between both primary hyperparathyroidism and hereditary familial hypocalcemic hypercalcemia? By doing calcium create ratio. If it is less than 0.02, this is a familial hypocalcemic hypercalcemia. So again, parathyroid hormone is very, very important blood investigation to be done next to or after the basic investigation. If you found that parathyroid hormone is normal, which is called inappropriate normal or high, this is primary hyperparathyroidism or most probably primary hyperparathyroidism or less likely familial hypocalciuric hypercalcemia or lithium-related hypercalcemia. What if you found that parathyroid hormone is low? It means that this is a hypercalcemia secondary to malignancy or granulomatous disorder or lymphoma, right? So if you found that parathyroid is low, no need to think about malignancy at that time. In malignancy, you will find parathyroid hormone is low and no need for further investigation for malignancy at that time. Okay. Of course, you have, if the patient bisphosphonate, you have to stop bisphosphonate 6 weeks before parathyroid hormone because it can affect the result of parathyroid hormone. Thyroid function tests, we agreed before that a hyperthyroidism can cause mild hypercalcemia. So you have to ask for also thyroid function test to rule out hyperthyroidism. But in such condition, you find the patient has other symptoms of hyperthyroidism, including loss of weight, palpitation, sweating, polyphagia. Vitamin D. Vitamin D is very important as well to check for vitamin D toxicity. And to check for secondary causes of or secondary hyperparathyroidism. I mean, in the case of vitamin D level is low, you'll find it low in the case of secondary hyperparathyroidism with chronic kidney disease. What if you are suspecting primary hyperparathyroidism? So now we are going to ask for investigation according to the suspected diagnosis. If you found that parathyroid hormone is high, phosphate is low, calcium is high, so as we mentioned before, this is primary hyperparathyroidism or familial hypocalciuric hypercalcemia or lithium-related hyperthyroidism. At that time, we have to proceed for calcium to creatine ratio and 24-hour urinary collection of calcium and creatinine. If you found that the ratio below 0.02, this is consistent with familial benign hypocalciuric hypercalcemia, which is a benign condition and doesn't require treatment in all the cases. And also you have to take a step if you found that the ratio is more than 0.2, sorry, less than 0.02, the next step is calcium sensing receptor gene sequencing to confirm the diagnosis of familial benign hypocalciuric hypercalcemia. Also, if you are highly suspecting primary hyperparathyroidism, you have to do ultrasound neck or maybe scan to detect the suitable if this patient is candidate for surgery or not. And we are going to discuss later which patient what the indication of surgery in the case of primary hyperparathyroidism. Another investigation, if you are suspecting solid malignancy, if is suspected at that time, why you suspected that malignancy is there? Because parathyroid hormone is low, okay, and calcium is high, and there is red flag symptoms like maybe loss of weight, fever, shivering, anemia. But of course, in some cases, you can find the patient doesn't have red flag symptoms or signs. So in any case of low BTH level and high calcium, you have to do further investigation for malignancy, including tumor markers and CT cap to rule out any solid malignancy. If MM is suspected, multiple myeloma is suspected, at that time you have to ask for serum and urine protein electrophoresis and immunoglobulin and skeletal survey. You'll find these patients with multiple myeloma are coming with renal impairment in most of the cases, renal impairment and body ache and backache. At that time, you have to think about multiple myeloma and send for investigation for MM, including serum urine protein electrophoresis, immunoglobulin, and skeletal survey. What if sarcoidosis is suspected? A patient with sarcoidosis will come with PTH is low and calcium is high, but also he will come with another presentation, for example, lymphadenopathy, arthropathy, skin rash in the form of erythema nodosum. But of course, not all the patients are coming with the typical presentation of sarcoidosis. He can come with short suppressed secondary to lung fibrosis of sarcoidosis or lymphadenopathy. So if sarcoidosis is suspected, you have to ask for 125 dihydroxyvitamin D, serum AC, which is positive in more than 60% of these patients. And of course, lymph node biopsy if there is lymphadenopathy, which is the confirming blood test or a step or confirming investigation for sarcoidosis. Again, if MIN1 is suspected, because hypercalcemia could be a part of a primary hyperparathyroidism, and we agreed before that primary hyperparathyroidism could be sporadic or familial, a part of MIN1 or MIN2. MIN1, like you see, is a triad of parathyroid adenoma and pancreatic tumor, either gastrinoma or insulinoma. And the third one is pituitary adenoma. How to investigate for them? First of all, you have to investigate for all pituitary profile, including serum prolactin, TSH, ACTH, LH, FSH, insulin-like growth factor 1. This is screening test for acromegaly. And of course, MRI brain to rule out pituitary adenoma or pituitary enlargement. Fasting gut hormone like chromographine A, B, vasoactive intestinal polypeptide, VIP, somatostatin, glucagon, gastrin. These are the pancreatic enzymes for pancreatic tumor as a part of MIN type 1. So again, MIN type 1, including 3Ps, parathyroid adenoma, pancreatic tumor, and pituitary adenoma. MIN2, what if MIN2 is suspected? MIN2 is a triad of medullary thyroid cancer. These are 98% to 100% of the cases of MIN2, or pheochromocytoma, benign, as most of the cases are benign, 10% only are cancerous. And it can be involved in 50% in the case of MIN2. Parathyroid adenoma or hyperplasia, which are involved in 5 to 10% of MIN2. How to investigate for MIN2? Investigation for MIN2 is for medullary thyroid carcinoma, serum calcitonin, and ultrasound neck. For pheochromocytoma, you can ask for 24-hour urinary metanephrines or urinary catecholamines and the serum epinephrine. Actually, serum epinephrine is the most specific, so you can ask for it from the beginning. It's more specific. You can ask also for CT adrenals to rule out adrenal enlargement or adrenal incidentaloma or adenoma, I mean. This is if you are suspecting MIN2 as a syndrome involving primary hyperparathyroidism, which can cause hypercalcemia. This algorithm actually is very brief and important. How to approach a case of hypercalcemia or investigation, how to approach investigation of the case of hypercalcemia. If you found that calcium is high, what the next step? Basic investigation, like we discussed before, full blood count, bone profile, renal function test or UNEs, liver function test. Then next step is parathyroid hormone. Like you see here, if the parathyroid hormone is high, what does it mean? If parathyroid hormone is normal or high, in the case of hypercalcemia, it means 3 possibilities. The first one is primary hyperparathyroidism or hereditary familial hypocalcemic hypercalcemia or lithium-related hypercalcemia. At that time, you have to measure calcium create ratio to differentiate between primary hyperparathyroidism and familial hypocalcemic hypercalcemia. If you found that the ratio is low, less than 0.02, so this is probably familial hypocalcemic hypercalcemia, which doesn't need treatment. If the ratio is high, more than 0.03, probably this is primary hyperparathyroidism, which needs, at that time, you can consider genetic mutation or genetic sampling to confirm the diagnosis. Okay, this is if the BTH is normal or high. What if the BTH is low? What does it mean? What the possibilities at that time underlying cause of hypercalcemia? Either cancer or what else? Granulomatous disease like sarcoidosis, periodontitis, or TB, right? Okay. As you see, measure at that time if parathyroid hormone is low. The second step is to measure parathyroid hormone related polypeptide, which is paraneoplastic, secreted by solid cancers. If polypeptide related hormone is high, at that time, this is probably malignancy, solid malignancy. Okay. Also, if you are thinking about sarcoidosis as a cause, you have to ask for 1 and 25 hydroxy vitamin D. This is the one here. If it is high, this is lymphoma or sarcoidosis or other granulomatous disorder. All right. Or maybe vitamin D intake. Okay. If you have normal vitamin D and parathyroid hormone related peptides, you have to think about multiple myeloma at that time, and you have to ask for multiple myeloma workup. This is a brief screen or a brief algorithm for approach of a case of hypercalcemia. How to approach the investigation of a case of hypercalcemia. Treatment of hypercalcemia. As we discussed before, only patient with moderate symptomatic hypercalcemia or severe hypercalcemia need immediate treatment with IV fluid and vigorous hydration and anti-hypercalcemic treatment. Mild hypercalcemia doesn't require immediate treatment and they can be charged as outpatient and do further investigation as outpatient. So as we discussed, mild hypercalcemia, which is most of these patients are symptomatic, which doesn't require treatment. And just to be advised to avoid factors that can aggravate hypercalcemia, including thiazide diuretics and lithium carbonate, and to avoid dehydration, and to drink plenty of water, and to avoid taking high calcium intake during the daytime, less than to avoid to take more than 100 milligrams per day. Moderate hypercalcemia, such patient, if they are symptomatic, they have severe symptoms of increased polyuria, polydipsia, nausea, vomiting, or disturbance of level of consciousness at that time. These patients need admission and need immediate treatment. Severe hypercalcemia, regardless the symptoms, if these patients are symptomatic or symptomatic without or with or symptoms, such patients need admission and immediate treatment. What the treatment for moderate to severe hypercalcemia? First of all, the main treatment for all cases of hypernatremia is vigorous hydration, IV fluid with normal saline, and it should be between 200 to 300 ml per hour. It means could be 5 liters per day. But of course, you have to be cautious with patient with heart failure, chronic kidney disease, and chronic liver disease to avoid hypervolemia. Okay, what if you have hypercalcemia in a patient with heart failure, for example? How can you manage at that time? Are you going to give fluid vigorous hydration or to give fluid with precaution or to give fluid with diuretics? Yeah, you can give loop diuretic with such patient. Loop diuretics can improve calcium as well. So diuretics is a second one, can be given. What the indication to give diuretics if the patient has hypercalcemia with risk of hypervolemia, like chronic kidney disease, chronic liver disease, and congestive heart failure. At that time, you can give good hydration with diuresis at the same time. But of course, don't give diuretics in a case of normal patient, I mean patient without risk of hypervolemia. It doesn't indicate it. So the only indication if there is risk of hypervolemia. Okay. Calcitonin. Calcitonin is given in a case of refractory hypercalcemia. I mean, you are giving a lot of vigorous hydration, but there is no significant improvement of calcium. Or in a case of severe hypercalcemia more than 14, at that time you might be worried about arrhythmia, and you need to decrease the calcium level so rapidly or so quickly. At that time, calcitonin is the treatment of a choice which is acting so fast to decrease the level of calcium. Um, what is the dose of calcitonin in a case of hypercalcemia? It is 4 international units per kg. So in a patient with 100, for example, 100 kg, you can give how much? 400 international units, right? Subcutaneous state. In the patient with 70, so it's almost 200 international unit subcutaneous state. Can you repeat that? Yeah, you can repeat the dose of calcitonin every 6 to 12 hours. Okay. In condition that the patient is improving, I mean the patient is responding to calcitonin, you can repeat the dose to gain or to improve the calcium more quicker. And you have to bear in your mind that this patient may have tachyphylaxis to calcitonin after 24 to 48 hours. So it's just preferred to be given for 24 hours to 48 hours, not more than that. And of course, you have to liaise with endocrine team or to liaise with nephrology team before giving calcitonin. It should be given by specialist doctor actually, or by consultant. But just to be aware, calcitonin, the medication is given in a case of severe hypercalcemia more than 14 milligram per deciliter, or in a case of refractory hypercalcemia, which is not improving after vigorous hydration. Bisphosphonate. What the indication to give bisphosphonate in a case of hypercalcemia? Only if the hypercalcemia is secondary to malignancy. Not in any case. If the case or if the patient no in case of malignancy and he came with hypercalcemia, you can give bisphosphonate at that time. You can administer either zoledronic acid 4 milligram intravenous over 15 minutes, or bamidronate, which is 60 to 90 milligram over 2 hours. And you have to bear in your mind, zoledronic acid is preferred than bamidronate, by the way. You have to bear in your mind that bisphosphonate will be effective only after by the second or fourth day. So you can give it, but don't suspect the calcium level to improve within 1 day or 2 days. It can take 48 hours to maybe even 4 days to improve calcium level. Donozumab. Donozumab is a medication is given in a case of the patient is can tolerate or cannot be given bisphosphonate. I mean, if there's contraindication for bisphosphonate, like severe kidney impairment, for example, or severe gastritis or xenocrosis, these are the contraindication in a case of bisphosphonate. At that time, we can give donozumab as alternative to bisphosphonates. Corticosteroid. What the indication to give corticosteroid in the case of hypercalcemia? Only in a case of hypercalcemia secondary to granulomatous disease, like sarcoidosis or borreliosis or other granulomatous disorder. So only steroids are indicated in hypercalcemia secondary to granulomatous disease. And dosage of steroid, it could be 20 to 40 milligram once daily, and they can be given up to 5 days with calcitonin, of course. Sorry, not with calcitonin. So it can be given on its own, actually, in a case of hypercalcemia secondary to granulomatous disease. Calcium-mimetic medication. Calcium-mimetic, including cinacalcet. Cinacalcet, what the indication to give cinacalcet? If hypercalcemia is secondary to primary hypoparathyroidism or tertiary hypoparathyroidism or parathyroid carcinoma. Cinacalcet can be given in a dose of 30 milligram BID, and you can increase the dose gradually after 4 to 6 weeks and to reach to a dose of 90 milligram every 6 to 8 hours, even if necessary, to improve calcium level. So again, what is the indication of cinacalcet is only in the case of hypercalcemia secondary to parathyroid hormone-related disorder like primary hypoparathyroidism or tertiary hypoparathyroidism or parathyroid carcinoma. That's why it's very important to know what is the underlying cause of hypercalcemia, because as you see, the treatment is different according to the cause. We have general treatment in all cases of hypercalcemia, which is vigorous hydration. All patients with hypercalcemia, you have to give vigorous hydration, including 200 ml to 300 ml per hour, and to give precaution for a patient with high risk of hypervolemia. You can use diuretics in the case of risk of hypervolemia. But other treatment, calcitonin can be given to all patients with hypercalcemia. If it is refractory to treatment, refractory to IV fluid, or if it is hypercalcemia, severe hypercalcemia more than 14 milligram per deciliter. But after that, every treatment is indicated in special cases. So IV fluid, diuretics, and calcitonin are given for all patients with hypercalcemia. But it's very low. Huh? We are going to finish right now. So just maybe 1 minute to go again. Here, bisphosphonate in a case of hypercalcemia secondary to malignancy. Okay, donozumab can be given to hypercalcemia secondary to malignancy if bisphosphonates are not effective or contraindicated. Steroids are given to hypercalcemia secondary to granulomatous disorder, like sarcoidosis, periodiosis, or TB, or lymphoma. Calcium mimetic, which is cinacalcet, are given to hypercalcemia secondary to primary hyperparathyroidism, or parathyroid carcinoma, or tertiary hyperparathyroidism. Dialysis is indicated in a case of resistant and persistent refractory hypercalcemia after all the measures are given, including IV fluid, including calcitonin or other medications according to the cause. At the
Hello everyone. I'm sorry for the disconnection, but almost we finished. We finished the our session. I'm not sure if anyone can hear me.
Yes, I can hear you.
Yes, yes. We the last slide of the PowerPoint was dialysis, treatment of dialysis, which is in refractory cases of hypercalcemia not responding to treatment, either to IV fluid, calcitonin, or steroid, or others. Dialysis was the last option of treatment. It's nice to talk to you all, and thank you for attending this session today. And I'm sorry for disconnection because the laptop is shut down because of charge. Um, and your feedback would be highly appreciated for the next sessions. Thank you all, and take care, and see you later. Bye bye.